Well, welcome back, everybody. I hope you enjoyed your lunch. My name is Stephanie Gadwa. I'm the Vice President of the Economic Club of Canada, and it is my pleasure to welcome you back today. Before we begin, we're reminded and we respectfully acknowledge that we are on the traditional territory and home of Indigenous people. The Wendat, the Anishinaabe, the Haudenosaunee, the Chippewas, and the Mississaugas of the Credit First Nation, land steeped in a rich history dating back many generations. The purpose of our acknowledgement is to show our gratitude and our respect for their contributions and to recognize the role of treaty making in what is now Toronto. For those of you who aren't familiar with the Economic Club, we are this country's national podium of record and the only nonpartisan national public policy platform that unites leaders, innovators, and experts from various sectors to discuss and address key issues facing the future of our country. Our foundation is firmly Canadian, yet our influence spans well beyond our borders. Our commitment to fostering collaboration, promoting thoughtful debate, and encouraging action continues to drive all the work that we do. The Economic Club is more than just an event podium. It's a platform for transformative ideas, helping to guide Canada towards a more prosperous future. We are delighted to have partnered with Shoppers Drug Mart today to bring you today's luncheon entitled Reflections on Primary Care, Insights from Shoppers Drug Mart. Now, please help me welcome David Markwell, Interim CEO of Shoppers Drug Mart, to get our event underway. He's going to share a few remarks. Let's give him a warm round of applause.
All right, good afternoon, everyone. I'm really happy to be with you here today, and I really wanted to thank the Economic Club for bringing us all here together to have this important conversation about the future of healthcare in our country, including here in Ontario. I'm glad to be part of this conversation because it's so important to the future of our country. At a time when we know government budgets are strapped and elected officials at all levels are dealing with pressing and competing priorities, I think it's important for us to come together and remind Canadians that their urgent healthcare needs are not falling off the radar. Canada is a vast and beautiful country, but when you break it down, it's our neighborhoods that define who we are. The neighborhoods are where we work, live, and raise our families. Neighborhoods are the foundation of community. Neighborhoods are where we look out for each other and we look after each other. The healthcare challenges facing each of our neighborhoods can look different, but the common element is that Canadians want to see the action that the future of the system that we hold so dear. And so we've reflected on some of the shortcomings in our primary care system, and we realize we owe Canadians some answers and possible solutions. With that in mind, I'm going to spend some time today talking about a model of primary care that we think can hit the mark for Canadians, a medical neighborhood that empowers providers to step up and help physicians and patients in this hour of great need in so many Canadian communities. So thank you for creating the opportunity to do that today. And like so many of you in this room today, we're leaning in on the healthcare challenges facing our country, because across Canada and right here in Ontario, the reality is hard to ignore. People are struggling to access care. Family doctors are in short supply, emergency rooms are overcrowded, and wait times are growing. You might remember earlier this year, it was a cold and snowy January day. Hundreds of people lined up starting outside at 2 a.m. for the chance on getting on the roster of a new family doctor in the small town of Walkerton in Ontario. Some of those people in that line had not been attached to a family doctor in many years. In some ways it's hard to believe, but in many ways it's not. I know many of us in this room, along with family members and friends who have struggled to either find a family doctor or to see their doctor without waiting a long time. An estimated 6.5 million Canadians don't have access to a doctor right now. And recent estimates suggest that that number is 2.5 million people in Ontario, and this number will rise to 4.4 million over the next number of years. Here in Ontario, a prosperous province. Communities large and small are feeling the pressure, and so are the people who care for them. The Ontario government has placed a strong focus on combating the crisis in primary care by establishing the Primary Care Action Team, with the team's mission to attach patients to family physicians and primary care teams. This is all very good work, but the problem will persist and more needs to be done in the short term. We are at a crossroads. Our healthcare system, particularly primary care, is in crisis, and if we don't act together, the crisis will only deepen. The question we have to ask ourselves is, where do we find answers? And to be honest, we are obsessed with finding those answers. And let me be very clear about the ground rules here. We believe that healthcare should be public, equitable, and accessible for all, full stop. That is the Canadian way. Our path forward is not through private healthcare. It's about working with the system that we have to make it work better for everyone. And like I said, we've thought about this a lot, and so I'm excited to talk to you about our ideas today. But before we look ahead, I think it's important to look back. For us, innovation has always started from one simple belief: the best solutions are local, rooted in neighborhoods and communities. That's been true for more than 60 years, ever since our founder, Murray Koffler, found himself in charge of the family business after his father died suddenly and he became a pharmacist himself. It gives me great pride to say that our pharmacists in every corner and community across this country provide exceptional care to their patients. 6 decades ago, pharmacists weren't really set up to provide robust access, and the public didn't fully appreciate what pharmacists could do. So we looked locally for solutions, and we built up community pharmacy to create more access to the health services side of pharmacy. The idea of having a local pharmacy in every neighborhood, that was the vision. We also empowered pharmacists to own and operate the stores so they could focus on what mattered most: knowing and caring for their communities. This was the beginning of a model rooted in trust, access, and local connections to deliver health care in the patient's neighborhood. And that's still true today. Every Shoppers Drug Mart and Pharmaprix pharmacy is still owned and operated by a local pharmacist, the person you know and trust to provide not just prescriptions, but advice, care, and compassion, right there in your community, close to home. Because solutions to big problems almost always start with local remedies. About 5 years ago, we saw the signs the primary care crisis was deepening. We could see from our dispense data the demand for chronic medications was growing at the same time that patients were waiting longer between doctor's visits. And many patients didn't have a doctor at all, making it harder to maintain continuity of care and stay on track with their medications. Our instinct was to do what we've always done: look for a local solution. That first brought us to Lethbridge, Alberta. The city was struggling with a doctor shortage, a growing population, and an overcrowded ER. We opened our very first pharmacy care clinic as a pilot to see if it could help. On the first day, dozens of patients came through, and that continued. Pharmacists in the clinic see about 40 patients a day, many of whom who don't have a family doctor. Ultimately, we opened 2 more clinics in Lethbridge, and this contributed to a 22% reduction in non-urgent ER visits at the local hospital. A year later, in 2023, we were happy to hear that a similar model had been proposed to the government of Nova Scotia by the Pharmacists Association, a Made in Nova Scotia solution that we were enthusiastic to support. This initiative has now led to the creation of 46 provincially funded pharmacy care clinics across the province. These clinics have also made a measurable difference, contributing to a 9.7% reduction in low acuity ER visits. Late last year, we took our pharmacy care model to British Columbia, to the heart of the healthcare crisis in Surrey. Surrey is a city with some of the fastest population growth in the province and some of the most pressing primary care challenges, and we saw the same warning signs. Our original plan was to open 1 pharmacy care clinic, then we met with the mayor of Surrey, who challenged us to open 5, and just over a year later, we've opened 7. 7 local clinics, led by pharmacists, helping people access timely care right in their neighborhood. Now, there's no one silver bullet solution, we know that. It takes a collective effort, and many other organizations are contributing their innovative solutions too. Mobile mental health teams across PEI, staffed by a nurse or social worker and a paramedic, are relieving the strain on local ERs. Quick care clinics in Manitoba are staffed by nurse practitioners and registered nurses who can diagnose and treat minor health issues, providing access for those without a family doctor. We've seen other innovative ideas come to life in Nova Scotia, where new technology is being used to monitor patients with chronic conditions from their homes, enabling early intervention and reducing hospital visits. But in isolation, none of these projects can scale to the level we need right across the country. Of course, nothing replaces the need for provinces to train and recruit more doctors, and your government is doing this. However, the federal government estimates Canada will have a shortage of nearly 80,000 doctors by 2031. And so governments like yours are rightly increasing spaces at medical schools and recruiting from outside the province. But even with that urgent action, the pressure on the system is not going away and will get worse. Our population is aging, and chronic, complex conditions are only becoming more and more prevalent. Here's what we know. Expanding and decentralizing primary care works. That's clear from the examples I just talked about. And as a part of this country's broader healthcare system, we believe we have a responsibility to work to make it better. We could just keep opening clinics, but frankly, that's not good enough, because this isn't about us, it's about everyone in each of our communities and neighborhoods. We have to work together. Which brings me to what I believe is the future of healthcare in this country, the medical neighborhood. For too long, the model of primary care in Canada has not changed. It has been siloed and fragmented and has ended up defaulting to the emergency room. Putting untenable pressure on our hospitals, the medical neighborhood takes that pressure off, just like any other close-knit community. In a medical neighborhood model, we all share the load. Community mental health, physiotherapists, diagnostics, paramedics, nurse practitioners, and yes, pharmacists, sharing information and sharing responsibility for the same patient. A medical neighborhood connects the people and places where care already happens, so that no matter where you enter the system, you're connected, supported, and never left to figure it out alone. The neighborhood doesn't compete with the core healthcare team in the medical home model that many provinces are currently building. It complements and expands it. The medical neighborhood expands on this integration between healthcare providers in the community to meet the patient's primary care needs. It supports primary care providers to ensure their patients can access the care they need when and where it is most convenient for them. And it's built on trusted relationships and seamless communication and information sharing with programs and services in the region. The neighborhood also links to community services such as housing, home care, and social support, because we know health isn't just what happens in a clinic. Most importantly, it's centered on the patient experience. So what does that actually look like? Well, let me give you an example, one that could happen right here in Ontario. There's a woman in her 40s, a mother. She's worrying about some symptoms she thinks might be a sign of her diabetes getting worse. Her family has a long history of the disease, and she's very concerned. She hasn't been able to get to a walk-in clinic during the day because she's working, and then she has to look after her children. She goes to visit her community pharmacist later in the evening when a friend can look after her children. The pharmacy talks to her about her symptoms, checks her medication, tests her A1C levels, and then adjusts the dose of her meds and updates her shared medical record. The woman's family doctor is about an hour's drive away, but in a medical neighborhood, she has immediate access to the findings via a shared electronic medical record. Her doctor is immediately in the loop, and the community pharmacist and family physician now can collaborate on the next course of action. The woman is referred to the local diabetes education program within the neighborhood, and she continues to receive regular care, integrated follow-up at her community pharmacy and within her medical home. The result? Patient managed, all after hours, without missing a day of work and without ever using the emergency room. That's the difference. No wrong door, no wasted time, no gaps in care. A medical neighborhood model improves the patient journey. Patients will be triaged to the right provider and referred or escalated if the condition warrants it. Not only is there no wrong door, but there will be no dead ends along the way. Experience and outcomes should improve dramatically. So let's talk about the distinct elements of the neighborhood that make this patient journeys work. First is a digital front door, which means that from the first interaction with any provider inside the neighborhood, a patient is going to be able to get where they need to go. That feeds into triaging and referring with no dead ends, no missed faxes or phone messages that can leave a patient waiting and wondering what's next. In the neighborhood, there are clear roles and responsibilities for providers that everyone has agreed to. And this breeds a collaborative kind of care, leveraging the new shared health record where patients and providers can work together to drive better health outcomes. And it's not just life-changing for patients, it's game-changing for providers. Family doctors can focus their time where it's needed most. Pharmacists and other allied health professionals can use the depth of their education to work to a broad scope of practice. Hospitals can focus on the complex cases they're meant to handle. And every provider in the neighborhood is supported by shared information, coordination, understanding of their roles with mutual trust, and the common goal we all aspire to, better patient care. In fact, every interaction with a provider in the neighborhood supports the primary care provider in understanding and addressing their patients' needs rather than fragmenting that care. The neighborhood is also adaptable and flexible. If a family physician retires or has to leave the community, there's a structure in place to leverage other providers and find solutions for those patients. So the system starts to feel less strain overall because we see more efficient care delivery through reduced duplication of care and stronger integration. Now, I know this is not the first time you've heard someone in the healthcare space talk about needing to break silos and work more seamlessly together. So I want to take it a step further and get pretty granular about the 4 very tangible, very doable things we need to make this vision a reality in Canada. First is a shift in our culture, moving from siloed to shared purpose, from mine to ours. This sounds tough, but it's made much easier when everyone knows and agrees to their roles and scope. Second, patient care is triaged to the most appropriate provider. All providers will escalate care to the most appropriate provider and smooth the journey for patients who can focus on their treatment, not in navigating a complex system. Third, we need to look at the scope for healthcare professionals. Pharmacists, paramedics, and all other clinicians should be empowered to the full depth of their education to optimize their scope and patient access. We need all hands on deck to pull us through this crisis in primary care. The public will demand nothing less within this medical neighborhoods model. And fourth, the neighborhood must be founded on connected care and interoperability. Interoperability is a big word that means leveraging technology to create shared systems and real-time data connections that let providers see the same information and coordinate seamlessly. Yes, this means getting rid of fax machines and endless string of back and forth phone calls between a doctor and pharmacist to manage one patient request. And instead, it allows different health providers to contribute information into a shared, secure space where they can communicate seamlessly. We know that this kind of transformation in healthcare requires building consensus across governments, colleagues, and stakeholders, but we think it's worth it for what it gives back to patients and the primary care system. With the neighborhood, we can do more with the resources we already have. No question. So many of our physicians are swamped with administrative work, but in the medical neighborhood model, the combination of digital and technology solutions will cut that way back. It will allow them to bring more patients into their practices. Canadians are really clear. They want improved care and are ready for change. At Shoppers Drug Mart, we're ready to do our part. I'll commit right here today that we will make sure that when a patient visits a pharmacy, their doctor knows. We will invest in technology, partnerships, and quality systems that make that integration possible. And we're committing to do the work we can with all providers to make the neighborhood a reality. I'm very bullish on this. We can relieve pressure on the system, better support our physicians, restore confidence for patients, and bring healthcare closer to home. The medical neighborhood is not an abstract idea, it's a practical path forward. It's building on the many starts that are happening in pockets across the country already. At Shoppers Drug Mart, we are all in. We've been committing resources, effort, and expertise to building out this concept, and we're ready to do more. But we know it takes everyone in the neighborhood working together to deliver it. Conversations like this are just the beginning. We want to sit down and talk with every healthcare association and government across the country about how we can work together to accomplish our goal. And we welcome anyone in this room or beyond who shares this vision and wants to make it a reality. The best solutions are local, we know that. Start with the community, start with the neighborhood. I believe the medical neighborhood can transform primary care in 2025 and beyond, so let's build it together. Thank you.
Thank you, David. So now we're going to pivot into our panel discussion. So please help me welcome Pauline Chan, who will be moderating our conversation. And she's going to be joined by Dr. NP Michelle Acorn, Justin Bates, and Dr. Suzanne Strasberg as they do a deeper dive on this. Let's give them a warm round of applause.
Well, thank you so much for that very warm introduction. We have our panelists here, and I'm Pauline Chan. I'm a health reporter with CTV News. I'm so honored to be here with you today for this important discussion. We've heard some really interesting thoughts and inspiring ideas from David Markwell, and we have our panelists here, Michelle Acorn, Justin Bates, and Dr. Suzanne Strasberg, to go a little bit deeper into those ideas. Let me just start here with talking about what we've just heard. Let us start with hearing from each of our three panelists here about your initial reaction to the neighborhood concept. David laid out a compelling case for the medical neighborhood, and each of our three panelists represents a unique perspective. Do we have a volunteer for who wants to speak first? Michelle, do you want to speak first?
Hi,
Michelle
everyone.
will speak from nurse practitioner's point of view, and then Justin, maybe you can follow with the pharmacists. Yes, okay, we'll do that. So take it away, Michelle.
Great, thanks for the opportunity to be here today. I think the most compelling part of the vision is the promise of seamless person-centered care and integration. I think it's really important when we think about what the neighborhood creates, but more importantly, it's the creation of conditions for a living health and ecosystem specifically. If you think about primary care providers, whether it's nurse practitioners, physicians, pharmacists, and the rest of the community professionals, we need to work in concert together. No one person owns this, and I think we really need to really focus on what that looks like right now. In terms of actually the biggest challenge, it's operationalizing, it's coordinating, it's a concerted effort to ensure what our North Star is and compass, and as the person and not a patient, because when you say patient, it's actually health, illness focused versus health focused as well. We need to think about breaking down the silos and traditional hierarchies and traditional models of care and modernizing it to what is the local context. Additionally, we need to think about the electronic health records. As we know, they don't communicate in real time, and people need real-time care. Access is supposed to be about meaningful access, choice of access as well. And if we're going to evolve this, it's actually the funding models and the enrollment models that are challenging. We all are here and committed to the cause right now, and I think we need to get out of our own ways and remove some of the structural barriers and really just, as I say, blow it up. Things are working well, but let's really create a neighborhood where our goal is to support our citizens that are vulnerable and to be contributing to society best they can as well. Thank you.
Yeah, and that's a great jumping off point. When I think about this from a patient perspective, it's a no-brainer. And when we talk about stakeholders, be it in this room and beyond, whether it's associations, other healthcare practitioners, government, et cetera, everyone's in great alignment that we do need to innovate and evolve our healthcare system to fill the gaps and also to be prepared for the next crisis, because we're still reeling from the pandemic, and I think we learned a lot during the pandemic about how quickly we can mobilize, how we can have interprofessional collaboration in ways that we never thought we could before, adoption of technology. We just think about the COVID vaccine program as a microcosm of that. So we know we can come together, and we know we need to come together in a team-based environment to make this work. And I really think we have to simplify it for the patient, because our system is very challenging to navigate, and patients need to understand where they can go, and it's always going to be about access, convenience and access, and creating capacity in our healthcare system so that the right person is at the right place at the right time. We do not need people going into emergency departments when they can be served in the community by competent healthcare professionals. And we know that progress is slow. Scope of practice is very welcome in Ontario, and the latest package, certainly from the perspective of all healthcare providers, will be one of those enablers to maximize and optimize the competency in education, training of pharmacists, nurses, and beyond. But we know there's also multiple models of care. There are great examples today that we can build on, and this complements that. Doesn't take away from what is existing today or from any other provider. It adds to and builds on, and really there's a lot of lessons learned from our current OHTs and things of that nature. But this will help, and this will give patients what they need when they need it. And I think that is an impetus. We have a responsibility, a shared responsibility, to make sure the healthcare system is there when we need it as patients, when our families need it. And the next, I would say, crisis that's looming will be the unmitigated or unmanaged chronic disease. And this is where, in the community, if we can manage chronic disease better, we're going to keep people out of hospitals, and we're going to make sure that there's capacity in primary care to deliver on the promise that we have in our healthcare system, publicly funded and delivered by competent healthcare providers. So I think pharmacists clearly have demonstrated they're ready, and we have community healthcare hubs existing today, and we just have to leverage that. We have to have the will and the ability to work together to make it happen.
And Dr. Strasberg?
Hi. So we know that 6.5 million people don't have access to a family doctor or a nurse practitioner. We know that there are at least 20,000 family doctors needed. We don't grow on trees, and it takes a long time to train a family doctor. I've worked for the last 35 years or so at Jane & Finch in Toronto, half that time not in a multidisciplinary team and half that time in a multidisciplinary team. And I cannot tell you what a benefit that has been to my patients. We need to use the medical neighborhood as a way of increasing access, of increasing attachment. If I can work to my full scope of practice because I have people who are helping me do some of the things that I don't need to do, we can take on more patients in our family health team. It is terrible that there are 5.5 million people out there not getting access to preventative care. It's terrible that there are 6.5 million people out there that aren't getting their diabetes checked, their blood pressure checked, that there's morbidity and mortality because there's not enough providers. We need to work together. We need to increase access and attachment through collaboration. We need to build an integrated system so that we get smart data. We need to stop having physicians do things that they don't need to do that can be done just as well and probably in many cases better than I can do it. And so though I think those are the first steps. We don't have to reinvent the wheel. The wheel's already started rolling. We can just add to it to the benefit of patients in this province and in this country.
Thank you so much. Our next question is directed a little bit more towards Michelle and Suzanne. And it's a question about the practical side of things. The speech that David gave was very clear that the medical neighborhood complements and expands the medical home model, which is the foundation of our primary care. But in a practical sense, how do you see that working? How do we build the neighborhoods that it truly supports family doctors and nurse practitioners and helps them manage particularly complex patients, those chronic care patients that you mentioned, who have so many different needs, rather than creating more fragmented care like we've had in the past?
Thanks for the question. It's interesting. We have 6,000 nurse practitioners in Ontario. I'm not sure if you're aware of that right now. More than 50% are embedded in Ontario than across Canada right now. There was mention earlier about the primary care access team, and there's over a $2 billion investment to attach 100% of Ontarians to a physician or a nurse practitioner in teams. On top of it, we've also had the Canada Health Act, and here's the promise when we talk about universal health care right now and really mobilizing the neighborhoods right now where nurse practitioner services have been deemed to be physician equivalent. So for publicly medically necessary care, that will also be an opportunity to really leverage that. The synergies here, I think we need to talk about in terms of models of care. We have the traditional models of care in Ontario where it could be through a nurse practitioner-led clinic. There's 27 of them right now across Ontario. We have them in community health centers, family health teams, Aboriginal health centers, and integrated across many different systems that you might not have even appreciated. We talk about hospitals, but also it's long-term care and corrections, for example, and public health as well, where we then mobilize the expertise of the pharmacist as a medication strategist, not just for dispensing and administering. I think that's really important as well. We need to think about how we leverage our providers. So the nurse practitioner physician usually are the most responsible provider, responsible for longitudinal care, the connection, the hub, for example, as well, and also they're system savvy leaders. And then we bring in what the actual team looks like. What we sometimes underappreciate is patient choice and convenience. And we talk about attachment, but if it's not meaningful attachment, when they're getting their needs met close to home, for example, or in their trusted providers, for example, as in the registered nurse, the registered practical nurse, the pharmacist, we need to really think about what that looks like as well. We complement, we collaborate. It's not a competition. We don't actually have to have turf wars. And the beautiful part about scope expansion and delivering of care is called boundary work in research, but it actually enhances safety and complements care. We all experience admin and reductions, and we're trying to get rid of paperwork, but what we're trying to really remember is where we're going for the North Star, and this is about person-centered care. And if we really know the neighborhoods, the patients or people should not have to be responsible for just navigating them. We need to make sure it's a meaningful experience for them. And also, from a health workforce perspective, we need to ensure that our health workforce is here for recruiting and retaining. And if you're not working in the conditions you wish to work in and provide that level of care, that is one thing for not just onboarding or stay boarding in these medical communities, in the medical neighborhoods as well. The beautiful part about it, I know, for example, Jason and I have worked together so many times now. It's the collaboration, it's building allyship, and remember where we're trying to move forward in common purpose and goals as well.
I promise that's not my alter ego.
That's okay. Yeah, we're good.
So I think a couple of things. One record, one patient, one record, full stop. Okay, that's the huge elephant in the room. We've been talking about it for 2 decades. We need hospital computers, EMRs to talk. We need family physician EMRs to talk. We need to be able to get records of medicines from diagnostic clinics. We need to get records from pharmacies. We have to balance the importance of PHI, patient safety, and the ability to get the information so that tests aren't duplicated and healthcare providers know what the heck is going on. That's the first thing. The second thing is you just got to start. You need to clarify roles and responsibilities. You have to understand, you have to have procedures in place. You have to just start. Get a bunch of teams, get a bunch of healthcare providers, get a bunch of resources in your community who share the desire to improve access, to improve care for people in Ontario. And then you can go to a place like Centre for Effective Practice, and they can help you with the procedures that you put We don't have to invent the wheel. We've got lots of teams. And then last thing I would say that we need to think about is a hub and spoke model for primary care providers, especially family doctors, working in solo practices, not in teams, where patients in Ontario don't have access to all these extra allied services. There's two tiers of medicine: people who see family doctors in fits and people who see family doctors who are not associated with allied health professionals. Let's work in a hub and spoke model. The primary care team or the primary care providers in the middle, and the spokes go out to other allied health professionals, whether they're pharmacists, physiotherapists, long-term care, home care. All of those things can be provided in an integrated way, in a way that it creates access, in a way that allows the patient to see the provider who can provide them with the best care in the best location. But we can't do that without one record, and that's the big elephant in the room.
And I just want to go back to that for one quick second, Suzanne. Is there, back in the old days, it used to be concerns about privacy, confidentiality. Is there any need to be concerned about that at this stage with the kind of technology that we have?
So I'm not a lawyer. I never wanted to be a lawyer. Many physicians think they are. I have enough in my family. But I'll just tell you one story and see how you would feel. Think of yourself as a patient. I was the provincial primary care lead at Cancer Care Ontario. We had tens of thousands of positive fecal occult blood tests in our record base with no follow-up after 6 months. And I wanted Cancer Care Ontario to inform the family doctor, because 1 in 20 people have colon cancer if you have a positive fecal occult blood test. And I fought with the lawyers who said, we can't do that because that violates our legislation. So we have to find a way where patient safety and patient privacy are balanced. And some of those ways are bringing the patient in. You decide who sees your record. You can decide to show it to your physiotherapist or not. You can decide to show it to your pharmacist or not. But we have to be able to balance patient safety and PHI. And I always thought, at least, that people would rather know that they had a risk of dying of colon cancer than being upset that their family doctor was notified without their knowledge.
All right. Moving on. The model isn't just about technology. David's speech called for a shift in culture and harmonized scope. So for Justin and Michelle, your members that you represent, nurse practitioners and pharmacists, are trained to do more than ever now. And how do we build the defined roles and processes so that every provider can confidently work to the top of their education? I know, nurses have always sort of covered all the bases, but pharmacists in recent years, they're doing more and more vaccinations, and I always wondered if the pharmacists complained about having more and more work put on their plate, but they are certainly capable of doing so much in our healthcare system. Do you want to start, Justin?
Yeah, no, I'm happy to comment on that. I think like any healthcare profession, they're being prepared through the curriculums in the schools of pharmacy, and I think the idea around this competency in education, it's very consistent now across the country. And I think if you talk to most pharmacists, they would want to do more. They want to look after their patients. And one of the most frustrating experiences is having to turn a patient away because you can't do something that you've been trained to do. And that's really looking at it holistically, as pharmacists look at it from the perspective of they're on the hub model of being on the front line, they're accessible. We saw that during the pandemic, really a paradigm shift when we started to do more than medication management and dispensing. with vaccinations, with counseling, and looking after a patient's healthcare journey and managing their healthcare needs. In some cases, that's referring a patient, whether it's to an emergency department or to another healthcare professional. But being that triage in the community, I think, is really important. I mean, there's always going to be workforce support and infrastructure that needs to keep pace, and that's something that, from an association standpoint, we look to ensure that we continue educating healthcare professionals and pharmacists, and that we support them in all the ways in the workplace that they need to be supported. But it's really has to be in tandem. One has to lead the other. And I think the culture shift here is so incredibly important, because it's not about taking from one to give to the other. And in my view, it doesn't have to be co-located. It doesn't have to be just a physician leading it, or a nurse, or a pharmacist. It can be all of those things. And because we have such a significant gap in our healthcare system, it has to be all those things. And we don't have to reinvent anything. A lot of this is already in place. It's been demonstrated already in multiple jurisdictions, domestically as well as internationally. What we need to do is start to really put it into place. And I think you, Suzanne, mentioned that, we have to start breaking down some of the barriers. Some of that is scope. Some of that is traditional way of thinking. But if we think about it from the patient journey, what does a patient need? How do we make it simple for them to understand where to go, who can do what? We will then start to create that culture shift, because we see it with minor ailments prescribing in Ontario. Almost 2 million Ontarians have gone to a pharmacist. And that's a building block for moving this paradigm shift, where pharmacists are counseling patients and helping manage and working in a team with other healthcare providers. It's happening now. We just need to expand, and we need to do that quickly.
All right. I'm keeping an eye on the time. So Michelle, if you want to talk about the idea of culture, try and keep it succinct so that we can get to a couple more things.
Absolutely. I want to go back to your point about nursing, actually, because I think it's important you realize the categories of nurses. There's registered practical nurses and registered nurses. So for a scope of practice, prescribing would be a narrow prescribing for registered nurses that's come out recently. Nurse practitioners are very different. They have experienced about 8 years as registered nurses and then continue on with graduate level education, marrying nursing and medicine. In terms of their competencies, they can admit, treat, and diagnose. They're autonomous providers and independent. They can do medical assistance in dying, for example, broad prescribing, broad diagnostics. So that's important. And we tend to kind of think about, and I think it's challenging the status quo and innovation and being a bit more disruptive of how we think about nurse practitioners in the mental model of physician and nurse practitioner, help with attachment. Nurse practitioners tend to get bucketed into the allied team, and that actually sometimes it becomes a problem as well. So I think that's really important to reinforce right now as well. And the models of care and the conditions of work. If we're going to really utilize health workers at their top of their scope, sometimes nurse practitioners traditionally have been in employee situations, but as you mentioned now, some are in solo practices right now, or if there's organizational barriers that are preventing that to improve access to care for our people, I think that needs to be enabled and empowered, because we're already entrusted professionals as well. I'll stop there so we can get to other questions.
Okay. We have about 5 minutes left. And one question which was sent to us from the audience I thought was interesting, so I just wanted to get that in, and then I'll give you guys each a chance to sort of wrap up with your final thoughts. But one person was asking about AI, and is the sector using AI effectively? Can you give some examples about how we can develop comfort in trusting the use of personal health information? Maybe I can start with you, Suzanne. Your thoughts on AI in the healthcare system right now, and how is it being used?
So it's an emerging field. There's still a lot of work that needs to be done with it around regulation, and the Canadian Medical Association is looking at that, but it's being used, and it's being used a lot. AI scribes are being used in medicine, and if you speak to physicians that are using them, they're loving it, especially a doctor that has to do an 1.5-hour consult for a behavioral issue. They don't have to type. We can sit there, we can look at you, And then at the end of the encounter, after you've left the room, the note's there and we can make sure that the note is accurate. I use it quite often. There's an app called OpenAI, and I just used it on a patient that was still clearly sick, even though her workup was entirely normal. I put in what the symptoms were, what the tests were that I ordered, and it spit out a bunch of differential diagnoses that I might not have considered. In terms of physician burden, a lot of the burden and burnout is around forms. We love seeing patients. We flippin' hate forms. And some of the work that's being done now is that you'll be able to put the form into the EMR, and it will do the first cut at filling out the form based on the information in your EMR. And then you can look at it and decide what needs to be changed or what needs to be added, what's inaccurate or what's not. So there's going to be a lot of work done in AI. One of the last things I'll say that I was really pushing for I was a panelist at the recent OMD, Ontario Medical, OMD conference, and one of the things doctors would really like is let AI go through our inbox, because I could have 200 things in my inbox in a day, and pick out all the normal ones, and just send it to the patient's chart. And then I just need to open the documents that are abnormal. That would save me a lot of time after work and would make a big difference.
Justin?
Yeah, I think all of those things are spot on. I think AI is an incredible tool to help with some of the burdens that you've mentioned around administrative burden, but also in prioritization. But of course, like anything, it needs to be applied appropriately. It needs to have the appropriate policies around it so that we don't have a misuse of it or mistakes, because AI is not always correct either. So it doesn't replace the human element, but it adds efficiencies and more effectiveness to many of the tasks and can ultimately free up time to see more patients, which is the ultimate goal. You want to see the patients effectively and efficiently, and there's no doubt that AI is transforming the way that practices are being established and implemented, and the way patients are being cared for in the community. So I think we're just at the beginning stages of determining how best to use AI, but there's no doubt that we're going to see an increased use of it in healthcare setting.
Michelle, AI in nursing?
Unequal access to AI and how it's actually funded. And I think the other piece, and it's not just nurse practitioners in nursing, it's actually the allied team as well, is how are we actually educating? There's a significant generational divide along our health workforce right now, and I think we need to ensure entry-level competencies and advanced competencies and how we're actually utilizing that, not just for differential diagnosis and care, but tracking accountabilities and measures and informing data in the future as well.
And we've got about 1 minute left. So Michelle, one final statement from you, medical neighborhood. You can comment on the things that you see as hopeful, maybe some of the challenges.
Absolutely. I think we, nurse practitioners specifically, are among the coalition of willing and allies as well. The intention here is to leave no one behind, and I think if we really leverage our health workforce and think about our local communities, and more importantly, go outside of our circle of care that are traditional, it's important. Let's actually think about crucial conversations, and that's when emotions are high but stakes are higher, and that's people's health and their choice as well, and help them to obtain their best health and to retain and onboard and stay board our interprofessional teams for rewarding careers, satisfaction as well.
Justin,
I think it's really about getting it done now, because I think patients are ready, and survey after survey, patients are ready to access services in multiple different ways. They recognize the gaps, and that the real, I think, thread in all of this is going to be working together, not looking at it from a competitive standpoint, but really seeing the professional collaboration and the results. And that's the culture shift, and then it's the leverage what's there today. There's a lot of infrastructure, a lot of health human resources that could be better used. Pharmacy is one example, and there are many others. And if we could do this together, with the support of government and breaking down some of the barriers, I think we'll achieve a lot. And we need to show incremental progress. We don't have to solve it all tomorrow, but we need to start moving it in the right direction.
And final words, Suzanne?
So I would say the status quo is not acceptable. We all know that. We need to do something about it. We need to start, as I say, somewhere. I think you need to start working with the leadership. One of the things we definitely need to do is to get the federal government to create legislation to require interoperability. We need to have a discussion about PHI and patient safety so that we have good data, smart data, and it's integrated. At the provincial level, we can start working with, have discussions with government around resources, and this is already in the Ontario government strategy, so it's a win-win for them if this moves forward. Patients are ready, and at the local level, and because this has to be a bottom-up solution, what it looks like at Jane and Finch is going to look totally different at Yonge and Eglinton. Start with people that want to work together. Find people who share your goals and your passion and start. Get your procedures and policies in place. It doesn't have to be perfect. Run it like a PDSA cycle and quality improvement. Plan, do, study, act. And after you've done it for a while, go back and make it better. We need to do this for people in Canada. We can't keep doing what we're doing now. It's a shame. So that's what I have to say. Thanks for listening.
Thank
My
you so
husband
much.
doesn't.
Thank you so much to our three panelists. We hope we've left you with some interesting thoughts for the rest of the day. Thank you so much.
A final thank you to Pauline, Dr. Acorn, Justin, and Dr. Strasberg. On behalf of everybody at the Economic Club of Canada, a big thank you for joining us today. Thank you, our friends at Shoppers Drug Mart. Thank you, David, for joining us today. So this concludes the end of our fall 2025 season at the Economic Club, but please mark your calendar for our first event back in 2026. We are hosting on January the 7th our Economic Outlook Breakfast. If you're not familiar with this event, this is our marquee event that we do every single year. Vashi Kapelos from CTV will be moderating the 6 chief economists from the big 6 banks as they unpack their predictions for what's to come in 2026. This event sells out every single year. It's one you won't want to miss. Limited seating is still available. You can find registration details on our website. If you have any questions, please let us know. Thank you for joining us today, and we'll see you next time.